Okay, so I'm charged with talking about a very controversial issue, and that is bipolar disorder, but then I was actually pulled back. I shouldn't talk about bipolar disorder. I will just talk about the medications, which I will do. So I will not talk about phenomenology at all, just since you talked about DSM, there is obviously a possibility of this TDD or TDD with dysphoria. We will see what will come out of it. Let's not talk about it now. And look at efficacy. There have been 5 medications that were tested against placebo and have all, 5 antipsychotics I should say, have all beat placebo. 4 of them are FDA approved: olanzapine, aripiprazole, risperidone, quetiapine. The study with ziprasidone had, after FDA review, some issues at the level of the sites. So they had first denied approval and had actually told them to redo the whole study, although they are now off patent. They didn't get the 6-month pediatric patent extension, but I heard that they're still renegotiating, weeding out the bad cases and trying to see whether there is, I think, still significance. So we will see whether they will get FDA approval or not. What's interesting is that at each dose, 3 or 4 week studies, the antipsychotics separated. Well, the valproic acid extended release did not. That was an industry-sponsored approval trial, FDA approval trial, and in an unpublished study by Bob Kovacs, only valproic acid immediate release separated, whereas lithium did not. So it seems that we have some problem with mood stabilizers in pediatric mania. Here you have a topiramate study and oxcarbazepine study, which did not separate, which is not surprising because those are also not indicated in adults. But again, here the lithium and the valproic acid ER are an issue. Even in adults, the extended release valproic acid did not do as well as the immediate release. There seems to be something about really getting a peak value. And so in kids, it should not be given as extended release. So maybe we should make that as a recommendation, which actually I didn't do there. We should add that. Looking at response rates, different from schizophrenia, where it was very hard at 6 weeks for individual doses to beat placebo for response status. So it's harder to treat psychosis. When you pool the data, it looks better. But for mania, each individual dose separated very nicely for every medication. Showing you again, these antipsychotics are much better in treating mania in a short period of time, 3 to 4 weeks, than psychosis at 6 weeks. So it's harder to treat schizophrenia than mania. Again, except for this one valproic acid IR unpublished finding, none of the other mood stabilizers, lithium or antiepileptics, beat placebo in terms of response rate. So that opens up the question, are antipsychotics more efficacious than mood stabilizers for mania in kids, which is not true in adults? So we did a pooled analysis that was published in 2010, looking at effect sizes, which were 0.65, which is roughly around what we see in adults for atypical antipsychotics for mania, but it was only 0.24 for all mood stabilizers. And when we removed topiramate, which is not an anti-manic agent, we actually only got to 1/3 of the effect size compared to a second-generation antipsychotic. So that's quite dramatic a difference. And then for response, significant, a number needed to treat was 4 in a pooled fashion, and non-significant for the mood stabilizers. For remission, again, number needed to treat was 4, and actually they were worse. Minus means that you're reversing the number needed to treat. It becomes a number needed to harm. Now this is pooling everything together, including topiramate, including also oxcarbazepine. But there's a clear signal. However, you could say, wait a second, this is all indirect comparison, different studies in different patients at different times. Fortunately, we now have head-to-head studies, and the story is exactly the same. So quetiapine, when added to valproic acid versus placebo added, so this is a combination study, did not quite make it in terms of separating, but again, this is in patients who've already had a partial response. But there was a significant effect for risperidone, and particularly here in the team study for risperidone. And when you look at response rates in each of the studies, it is significant. So huge differences, quetiapine versus valproic acid monotherapy, that was quetiapine added versus placebo added. That's combination. That's not so surprising, but here, a Mani Papuluri study, risperidone versus lithium, versus valproic acid, huge difference, and the same in the team study, and looking for remission, the same thing. So there seems to be an effect of dopamine blockade that is stronger for pediatric mania than mood stabilizers, and that is not the case for adults. This month, Ben Vitiello did a nice sub-analysis of the team study comparing risperidone with lithium. So the better mood stabilizer, trying to find out, are there certain symptoms that drive this difference? Because as you know, pediatric mania has much more mixed episodes, much more rapid and ultradian cycling, so it might be a different phenotype. And what he found was anything below 0.2 is basically negligible. So there's no difference between lithium and risperidone for elation, for decreased need for sleep. So those are core typical mania symptoms. So one big criticism of these studies, of the industry-sponsored studies, has been when you do a comparison in adults, that the levels were only 0.7 or so in acute studies for lithium, for example, and they were also not the high range for valproic acid. So this comparison always seemed a little biased, but these are studies from independent investigators, and the levels were usually good. I don't remember, it was I think 1.0 for lithium in the team study, and it was oh yeah, I have the levels here, yeah. No, that's 1.1, exactly. 1.1 and 114 micrograms per milliliter. So you see here, this is pretty good, 96 and 100 for valproic acid. So it's usually not, and the doses for risperidone were not whopping, yeah, because these are younger kids. So I think it's not biased by the levels. For the typical mania symptoms that are more the adult type, there is no difference. Lithium is very good. It's not better than risperidone, but it's equally well. Then we have some symptoms that are just approaching a minimal or mild small effect size difference: accelerated speech, racing thoughts, poor judgment, and motor hyperactivity. So it's not just the sedation that risperidone might confer, but then the big, or here we have intermediate moderate effect size or higher small effect size, distractibility, and as to be expected, the psychotic symptoms. But that's not what drives the overall score, correct? I mean, it's not like anybody who had psychosis that sways the whole effect size. Not even mood lability. What does it is flight of ideas, grandiosity, goal-oriented activity, and irritability and anger, as to be expected. So it's not just the sedation, it seems, but clearly more the accelerated or dysregulated symptoms seem to respond better to the antipsychotic. And that's, I think, something for us to bear in mind. But I saw in the guidelines, even in 2010, we had taken that into account and really had put atypicals first, and then second line was another atypical or a combination, or monotherapy or combination with mood stabilizers. I will not go too much through side effects, very cursory. Females of childbearing age should not get valproic acid because of the much accelerated risk of polycystic ovarian syndrome. Although it's not everybody, it's 1 out of 10 girls, but still it's a risk that is 7.5 times higher, and it happens only in the first 6 months, so it seems to be a real reaction to valproic acid. Suicidality has also been associated not only with antidepressants, but with anti-epileptic drugs. There seems to be something in the younger folks where this is a risk factor, so we need to monitor for that also with mood stabilizers. There's no warning for antipsychotics. And in terms of side effects compared to mood stabilizers, no surprise, somnolence is obviously higher, as is weight change. Although when you take topiramate out, there's also weight change at a 0.48 standard deviation or effect size with lithium and valproic acid. So we shouldn't discount that those mood stabilizers can also cause quite a bit of weight gain, particularly when given early on in the treatment of these folks. There was less discontinuation due to intolerability, though, compared to mood stabilizers. This was not statistically significant, but it was after every 20th child with antipsychotics, and it was after every 9th child with a mood stabilizer. In terms of other side effects, so basically comparing this against also adults, children and adolescents were at higher risk for somnolence, a higher risk for hyperprolactinemia, but not higher risk for akathisia. So akathisia doesn't seem to be an age-dependent phenomenon. Might also be that the titration was a little slower with the atypicals compared to in children compared to adults, where often 30 milligrams of aripiprazole was actually given as a starting dose, and that can cause early restlessness, whereas if you start at 2 milligrams and then go to 5 and then go to 10 and then go to 15, even if 100 patients ended up at 30 milligrams, there was a much lower rate of akathisia. Okay, what's important is also monitoring. We've talked about this briefly yesterday. The guidelines for the metabolic side effects include for adults baseline 3 months and annually, based on no direct data, but on the concern that kids have higher weight gain and greater risk for early side effects in terms of metabolic derangement. We proposed a 6-monthly monitoring rate, but again, there is no organization behind it or so. This is just what we propose. So you're still fine if you say annually, but even in the APA guidelines, when we wrote those, there was an asterisk, or if you have severe weight gain, more than 7%, which almost all our kids have, then you should do it earlier, or if you have a high-risk group, and that would be Hispanics, African Americans, people with a family history of diabetes. So we're getting more into the range that kids might need higher monitoring.